Today we're very fortunate to be at the Alzheimer's Association meeting in Toronto, and we're fortunate to be joined by Dr. Laura Baker. Dr. Baker is a professor of gerontology and geriatrics and internal medicine at Wake Forest University, and she is one of the principal investigators of the US Pointer Study, which is one of the leading pieces of research that is being released at the Alzheimer's Convention this year. And we're very pleased that you would take your time in the busy schedule. There's a lot of stuff going on, but we're excited to have you join us. And I'd like to just start off by, the Pointer Study. It's a big study. I was hoping you could kind of give us a little bit of context. What's the study about? What were some of the key findings?
Okay. Well, first of all, I'm glad to be here. So, and we're just thrilled to be able to present a positive clinical trial finding at this meeting. So, US Pointer is the largest completed lifestyle intervention study in the world, not just in the United States, but in the world. And I think what's important about Pointer is that we're able to use science using a very rigorous method of testing whether lifestyle intervention, lifestyle change could actually benefit brain health for older adults who are at risk for cognitive decline. The science part's important. I think I hear all the time that, I know that what I do to my body, how I take care of my body is good for my brain. I know what I should be doing. We all know that. But to actually have scientific evidence to show what you need to do and what is the magnitude of the difference, we're hoping that that extra element, that scientific proof, is going to help us start to change our ways across the United States, hopefully across the globe.
Interesting. So what exactly were you looking at in this study?
Okay, so US Pointer is a study where we are testing two different lifestyle interventions. And they may not appear different to everyone, but they're very different to us. And we're looking to see whether those two lifestyle interventions improve or protect cognitive health, and if there might be any differences in how those two interventions affect cognition over time in these at-risk individuals. So the interventions they both focus on just some core pillars of healthy living. So getting physical exercise, nutrition, staying socially connected and intellectually challenged.
Interesting.
And knowing your numbers. Knowing your health numbers. Those are really the four, and I'm putting together staying socially challenged and intellectually challenged as one of the core pillars.
Right.
And so those were our four areas of focus for both interventions. Okay, so how did they differ? So participants could be randomized to either assigned, like flipping a coin, to either the structured lifestyle intervention or the self-guided lifestyle intervention. So let's just look at it in terms of the name. Structured provides a highly structured program to the participants about what goals they should be meeting for each of those core pillars on a weekly basis. Okay? And there's a lot more accountability. They're accountable for what they've done, and there's a lot more support. There are study-trained experts that are helping guide the participants along the 2 years. The self-guided is just that. The participants make the decision. They're not provided with a structured program. They say, here's what I want to work on in my life, and these are going to be my new healthy behaviors. This is my plan. This is how I'm going to make the changes. And then there's some support that helps them, trained support. These are folks that provide general support, not goal-directed support, which is a critical difference. And they help them kind of move through the 2 years.
So was the idea to figure out which is more effective, the structure?
Yeah. So we had a lower intensity, and so the question we ended up answering is, or tried to answer is, what about just a little bit of support? Can we move cognition? Can that show benefit? So that was the self-guided groups.
Just asking a little bit about the structure of the study.
Yeah.
You had the self-guided, and you had the the more structured, and you looked at the two groups. Question, you're talking about groups at risk. So how were you defining groups at risk?
So the folks that were coming into the trial, we really, I mean, in science, there's a lot of conversation about when is the right time to start an intervention. Is it when a person has dementia? Is it when they first start showing signs at a kind of a gray zone that we refer to as mild cognitive impairment? So it's not normal, it's not dementia, but it's in that gray zone. Is that the right time to start it? So with lifestyle, because we're trying to restore health to the body in order to restore health to the brain, we've got to have maximum substrate to work with. We can't have, if we've had loss of brain cell, there's only so much you can repair. So our focus in lifestyle interventions is to go back as early as possible.
Right.
And so our people were recruited into the study and they are cognitively healthy. They're okay. And if your readers are familiar with a test that's often administered in clinical care called the mini mental status exam, it's a 30-point test that's used very frequently in a dementia clinic, and you can go online and get the test. I mean, it's very easy, but it's a blunt instrument to test whether a person has significant cognitive impairment. It's not a test to see if a person's okay. But that test goes from 0, it's very hard to get a 0, basically you're not responding to the world at all, to a 30, and there's no problem at all. Our people on average have a score of 29. We are okay. Our people are cognitively normal, but they're at risk for these reasons. To get into the study, you had to meet 2 mandatory risks. 1, you're not a regular exerciser. If you're already a regular exerciser, you're taking your medicine. I can't help you, okay? Continue, don't stop. You're not a regular exerciser. In the United States, that's a very large number of people. Okay, not a regular exerciser. And even if you might ask, well, how much exercise could I be doing and still get into the study? So I have 2,111 people experience dealing with that number of people to share. We've heard everything. But in general, if people are casual walkers and that's all they do, they got into the study. If anyone ever said the word, I run or jog, even if it's at the slowest possible pace, they're not in. So we're trying to find that sweet spot in between. Are you challenging your heart? Are you getting exercise every week where you're having to breathe a little harder? If that's what you're doing, you're already doing the work. But if that never happens, casual work in the garden, but the heart is never challenged, you're in. So that's how we were defining not a regular exerciser. You had to also not already eating a healthy diet. So if you're already following a strict Mediterranean diet or a strict American Heart Association diet, we can't help you in that domain. Again, for the United States, a very large number are not getting adequate nutrition on a daily basis. We all get adequate calories, but not adequate nutrition.
Were there any cognitive tests?
In order to get into the study, you had to have those 2, the mandatories, but then also 2 of the following. Either suboptimal cardiovascular disease health measured by borderline high LDL cholesterol, borderline high sugar levels, hemoglobin A1C, blood sugar, or borderline high systolic blood pressure. Any one of those gave you a point. If you were over the age of 70, so the older part of our age range, you got a point. Higher risk for decline. If you were Black, African American, Hispanic, Native American, Pacific Islander, another point. Those folks from these subgroups, from these race and ethnicity background are at higher risk. So you get a point there. If you were male, you got a point. If you have family history, actually there's 5. If you have family history of significant memory impairment, don't even have to know what caused it. That was a point. So it was 4 points. You got some options. What that did is allowed us to recruit a enriched risk group of people, and that risk is there for many reasons. And that's what we wanted, because we wanted to have more generalization to the population.
Was there a bottom on the age?
60 to 79.
Okay.
Yeah, so you're right. That's another mandatory requirement.
Because I'm 65.
Yeah.
I don't think I know anybody in my peer group who would not, to some extent, confess that they have a bit of cognitive decline. So that's
Yeah,
that's what's interesting to me about hearing about this study.
Yeah. So you asked the question earlier just about that. You know, is there a minimum cognition you needed to get into the study? Especially in light of our conversation, we wanted to go find people who were earlier in this kind of pre-decline.
Yeah.
Well, first point to be made, as we get older, the biology, the cognitive clock is such that it's always ticking.
Yep.
It's part of being a human being. It's just what happens. And so what we do is we live with it, we adapt, we adjust, we, live life on the fly. And that's a healthy response. So we all have a biological clock and a cognitive clock. It's always ticking. Things are always changing.
Right.
So it's normal. Yeah. So the kind of changes we all experience, I'm in my 60s as well. I experience, thank you. I experience change all the time relative to in my 20s. Yeah. But I also have other skills that I didn't have in my 20s. I know how to prioritize my time. I know how to stay focused. I know what I care about. And I disregard things I don't care about anymore. So I learned strategies to keep me at my best.
Right.
So we're always changing. Even though we're always declining, what we care about is what's normal for that age.
Yep.
Okay.
So you do the test, you do the trial, you have the self-control group, you got the more structured group. What did you find?
All right, so what we were just, first of all, this was a positive clinical trial. That means we found a significant difference between the two groups. And I just want to, remind...
Were you surprised by the findings?
First of all, I've been a scientist my entire career.
But you also look like you're an exerciser. And
I am. I'm not going to ask anybody to do what I don't do myself. So I want to know what their challenges are, and I have to be able to relate to that. But in my career of running clinical trials, I've had a couple of...
How many clinical trials have you done?
I've been part of or led over 50.
Okay.
Okay, and I've had significant findings that I am excited about that are statistically significant in 8 out of 50. So whenever we get a significant effect of your controlled intervention, it's a reason to celebrate. And if you watch, all of the new drugs that are being developed for, any disease, there are way more failures. And I don't mean failures, null results. Yeah. Than there are positive. So anytime you get a positive result, we are celebrating. So we are celebrating this magnificent finding on something I care so much about. So what we found was that both groups improved, the self-guided and the structured group. Remember, the self-guided is getting more than standard of care. Both groups improved, but the structured group, the more intense, requiring more intense commitment, had a significantly greater benefit. And I think this next statement is important for people to know because everybody wants to know, greater benefit, how does that translate to my life? The greater benefit that we estimate is that it's as if the structured participants now, because of the intervention, are performing at a level that's similar to adults who are 1 to 2 years younger than they are. So it's pushing back the cognitive clock by 1 to 2 years by participating in this structured intervention.
So were you surprised by the finding?
Oh yeah. I always believed. I believed it always. I was just, otherwise how am I going to stay motivated to do this trial unless I have this feeling at the very beginning that I just want this to be true. But even though I know that, once we get started, it's imperative that the whole team stays in equipoise. So what I mean by that is it's not been tested in science yet. We think we know, we think we know what we want to believe, but until it's tested in a randomized, rigorous clinical trial, it's all opinion. And so our team got a lot of training about remaining in equipoise. We do not, in balance. We do not know which group is going to work, and maybe one will work better. Maybe the self-guided group would be better. Maybe the structure, we don't know. And we had all of our messaging to one another in our team meetings, and then to participants, total equipoise. We don't know the results. This is a clinical trial. We treat everybody the same. We treat everyone as if both interventions will be successful. So that is really a key point in a clinical trial where the participants they know what group they're in. It's not a pill that you're taking and you don't know what it is. So you have expectations. So it's really important to manage those expectations so that when there is a difference, it's not because anyone's treated differently, it's because one intervention really did have a bigger effect over the other one. And so I feel confident because we maintained equipoise in all of our communication that that's a real effect. It's real, that the structured group adds that much more benefit over the self-guided group. But you know, I'm always sensitive. Half of our 2,111 participants are in the self-guided group. So I'm very sensitive to how they're feeling about this. So I think the message that both groups improved is really important for the cohort. Is I feel responsible to the whole group. And so I couldn't be pleased more that both groups benefited. It would be so hard for me to talk about, even if it was a tremendous, you know, if the structured group was way higher than the self-guided group and we showed the self-guided group declined, that would be just extremely painful for me.
Two questions. First question is, what were the factors? Like what, of all of those factors, as I said, gets back to the question, all of us are feeling there's that little bit of decline. If we got to do one thing, what's the one thing that we should be, is it the diet? Is it the exercise? Is it the social engagement? Yeah. You looked at a number of factors. Were you able to find any correlations?
We will. You know, I am historically, I studied exercise, physical exercise. That's how I started in all this. I was an exercise scientist. And so I've published multiple studies, exercise only, nothing else. And then I got drawn into the multi-domain.
Interesting.
And there's I am I'm more excited now about multi-domain than I was about exercise alone.
Okay.
Yeah. The reason, you know, just learning, just if you know a little bit about the biology of the body and of the brain, that you know, each of these influences that we have on behavior, they don't operate in isolation.
Right.
You know, we are a highly integrated system that our biological systems lean on each other to get better. They do not. They don't stay in their own lanes.
Right.
Okay. And so when they cross lanes and they support one another to make benefit, how can you ever get that synergistic effect or even a higher dose effect when you're looking at just one domain at a time?
Right.
It may be that exercise alone is fantastic, but can you imagine a world where exercise plus a healthy diet might get you not only twice the benefit, but 3 times the benefit? It's that synergy that we've got some new data that we'll release later this year that will help us understand the mechanisms a little bit more. We have some brain imaging data and some objective sleep data and objective heart vessel and brain vessel data will help us understand what exactly is happening with the exercise, what exactly is happening with the nutrition changes. So that's going to come, but right now we believe, and this is partially science, partially just a strong conviction, that the science is that I understand the body and how the systems work together as partners, not independent. That biology just makes me have this conviction that it's going to be the combination that's going to have the bigger effect. And the other reason I believe in the combination is that it is more inclusive.
Right.
It includes more people. What about all the people who can't exercise? What if they have some physical disability and they can't exercise? So what are our options? What can I tell them? With a multi-domain, we have lots of options. If you can't, and we adapt each option, each domain we meet that person where they are. So if they have a physical impairment, what else can we do? Let's look at our portfolio to see what else we can give you to help change, you know, move you towards a healthier body. And I really am at a place in my life, in my career, in my age, that opening the door our intervention to more people in diverse micro cultures is way more important to me. I don't want to leave anybody out.
Right.
And we have so much of our science, we don't have diverse representation. we're leaving out people often who are in rural communities, who don't make as much money, who don't have access to health care, who are a different color, different culture. I am too old for that. My goal is to make sure that whatever we develop, it's for everybody. Otherwise, it's for me. If it's not okay for everybody, or if I haven't given that opportunity for everybody, it's a failure. Even if it's a successful trial, it's a failure for me. Right.
So, in order to make this trial a success for you, which you said on paper is a success for you, what do you see as the next steps of the data? Like how the program that you're describing, in either case, as you said at the beginning, is less than the typical standard of care.
Greater than.
I'm sorry, greater than the typical standard of care, right? Significantly greater than this. What would you see as what you would like to see as the next steps coming out of this? What does this mean from a public policy perspective?
Okay. Well, okay, so I have, is this a wish list?
Yeah.
Is this a wish list?
Yeah.
So let me start with the unrealistic wish list, but I wish it wasn't unrealistic. But my unrealistic wish list would be that this message is heard loud and clear. And that people who have power to help individuals start to make a change will step up and do so. And those people who are already living this life will reach out and bring their family and friends into the fold and help others, provide that needed support to help one another. None of us can change a habit without help. It's impossible.
Right.
So my wish list would be that there would be a slowly evolving health movement to support brain health across the U.S. And so that's, like, wow, that would just be mind-blowing. If it just, wow, look at the numbers of people who've changed, who are starting to really buy into healthy living, and look at it just go across the United States into all communities as a way. Okay, so that's unrealistic. But the realistic wish then is that we start doing it one person at a time. And one person at a time is using the ambassador model that we just talked about. If you're doing this, pull someone in, help someone do it, meeting them where they are. But also for communities to start taking some responsibility, getting together, talking to their leaders to say, how will it work in our community? How it works in one community doesn't mean it's going to work in another community, but even the small communities might even have more power to beta test. How can we get my community moving toward? And I know there are some communities around the United States who are starting this in response to some of the, some of the new work coming out. But I also want to say that the Alzheimer Association has a whole portfolio of projects that they're actually have started working on. They've already engaged several sites that have strong connections to healthcare systems.